Welcome to another video from the Heart Factory. In today's video, we'll be talking about the various aspects of priming the heart-lung machine, the ways to do it, and the various solutions that are used to prime the heart-lung machine. We shall also be discussing the effects of these fluids on the hemodynamics, on the heart, and on the body as a whole, and what the future holds for priming of the heart-lung machine. So without wasting much time, let's get started with this video. Now, even before the patient is shifted to the operating theatre, the perfusionist assembles the oxygenator and the reservoir in its holder and then aseptically connects the sterile tubing from the pump pack to the appropriate ports. The heat exchanger of both the oxygenator and the cardiopulmonary chamber is the first thing that is checked for its integrity prior to connecting the lines to the patient. The water temperature in the hemotherm is kept at normal temperature and circulated first through the heat exchanger of the oxygenator, and the integrity of this oxygenator is then checked. This is followed by the heat exchanger of the cardiopulmonary unit being checked for its integrity. Both the devices are ideally checked for any leaks. Now, priming of the oxygenator then proceeds, followed by priming of the cardiopulmonary unit. Now, what is priming, what is used for priming, and how much volume should be used is something which this video deals with. Now, our center and many others used a combined strategy of crystalloid and synthetic colloid. The crystalloid we used is called the plasma light A, which is a source of water, electrolytes and calories and contains physiologic levels of sodium, potassium, magnesium and chloride, apart from acetate and gluconate, which gets metabolized in the liver to form soda bicarbonate as a buffer. Now, the magnesium in this solution is important in cellular process of energy transfer and in myocardial ATP metabolism. The osmolarity of this fluid is around 294 milliosmoles per liter and corresponds well with the normal physiologic osmolarity, which should be around 280 to 310 milliosmoles per liter. Its pH is neutral. This fluid, however, does not contain calcium and may lead to hypocalcemia. Now, the synthetic colloid we use is called hydroxyethyl starch. Now, the synthetic colloid, like hydroxyethyl starch, is the one we use because they are inexpensive alternatives to albumin and have similar efficacy to albumin in maintaining the colloidal osmotic pressure for cardiopulmonary bypass, but is said to have some adverse effects on blood coagulation. Now, hydroxyethyl starch is a synthetic non-protein colloid solution that is derived from amylopectin, and the one we use is the third generation, which is usually described as 130/0.4. It's a low molecular weight starch which is developed with an improved metabolic elimination profile and is found to be safe for CPB priming. Now, the volume of prime required is either based on a standard empirically derived volume that should be greater than a minimum safe priming volume, or it may be guided by the patient's weight or the body surface area. The minimum volume required is that which fills both the venous and arterial limbs of the CPB circuit and maintains an adequate reserve volume in the venous reservoir to ensure that air is not entrained into the arterial side of the CPB circuit during the initiation of cardiopulmonary bypass. This volume is determined by both the caliber and length of the tubing connecting the patient to the CPB machine and by the capacity of the venous reservoir and oxygenator. Ideally, in adults, the priming volumes are in the range of 1400 to 1800 ml which roughly corresponds to 30 to 35% of the patient's body volume. Now, if you take the same in children, especially in infants and neonates, even the minimum priming volume will be far greater than their blood volume, making the use of non-blood primes impossible. The issue of selecting the right priming solution for cardiopulmonary bypass circuit is imperative and is mainly dependent on the cost, the ease of use, the maintenance of the colloid osmotic pressure, and minimum adverse effects. Historically, stored citrated blood was considered for priming, but was associated with hemolysis, transfusion reactions, viral particle transmission, and increased post-op morbidity, and therefore it was discontinued. This was followed by 5% dextrose to be used as a prime instead of blood, but dextrose when used led to hypotonicity and hyperglycemia with resultant bad neurological outcomes. Hence, 5% dextrose was also discontinued. Normal saline was used, but normal saline caused metabolic acidosis because of hyperchloremia, and hence normal saline was also not considered. Finally, an ideal priming solution which had the same tonicity and electrolyte composition as the plasma and the same pH as the plasma was looked for and was used to fill the cardiopulmonary bypass circuit. This system of using a priming solution led to hemodilution, which decreased the viscosity of blood and increased the capillary perfusion. Apart, with decrease in blood viscosity, there was also fall in the systemic vascular resistance, and there was better flow to the peripheries than compared with only blood as a prime. There was very less chance of viral transmission, and there was increased urine formation with prime. However, the required hematocrit to be maintained on cardiopulmonary bypass is about 25 in adults and 30 in pediatric age groups, and again depends on the clinical status of the patient. Now, crystallite solutions are a simple selection of priming as they are cheaper than colloids, they are free of anaphylactoid reactions, and are associated with improved post-op pulmonary and renal function. They lack oncotic activity and, when used in large amounts, lead to dilutional hypoproteinemia, low oncotic pressure, and tissue edema. Now, the normal range of colloid osmotic pressure is 25 mm of mercury, and a lower limit of 15 mm of mercury can be tolerated during cardiopulmonary bypass without leading to tissue edema and organ dysfunction. Now, colloids have the ability to maintain the oncotic pressure and reduce the tissue edema, but their use may be associated with an increased incidence of anaphylaxis and clinical coagulopathy. The first type of priming is called the gravity-based priming, wherein the main tubing from the main roller pump is removed and the oxygenator is allowed to de-air and prime by gravity to avoid splashing effect. What you're seeing here is the oxygenator is gently being filled only by gravity, and this is done to avoid the splashing effect. Now, once this is done, a bit of the arterial loop is also filled and clamped, later to be de-aired when the AV loop from the patient side comes into play. The recirculating line is a quarter tubing, and mind you, the pump is made to run at a flow rates less than 1.5 or 2 liters because the quarter-inch tubing wouldn't be able to tolerate more higher flows. And by recirculating the fluid through the recirc line, the oxygenator gets de-aired and primed, and the same recirc line which gives rise to the cardioplegia connection is primed. So before the AV loop from the patient side is received, the whole oxygenator complex is de-aired and primed, along with de-airing and priming of the cardioplegia unit through this quarter-inch tubing. So the flows here should not be more than 1.5 or 2 liters, lest it would lead to rupture of the tubing. So what you're seeing here is that the recirc line is clamped and the cardioplegia line is being primed. Now till now, the cardioplegia chamber was only checked for the integrity of its heat exchanger. But from now on, the cardioplegia chamber would be primed to the extent that the recirculation loop and the main line that goes to the patient is also filled to the extent that after receiving the main lines from the operating table, they'll be ready for cardioplegia delivery. The cardioplegia line is connected to the pressure gauge like the main arterial line, and the occlusion test is done. Now at this stage, cardioplegia hemotherm has to be cooled. The hemotherm is put on the cooling mode so that when the first cardioplegia is asked for, it will be cooled. Now this hemotherm is kept around 4 degrees centigrade and the actual delivery of the cardioplegia would be around 15 to 16 degrees centigrade. Now by the time the cardioplegia is asked for by the surgeon, there will be enough time for the perfusionist to collect blood into the chamber, allow it to be cooled and keep it ready for delivery to the patient. Now the other additives to the cardiopulmonary bypass machine includes heparin in the dose of 2000 to 3000 units per liter of prime, mannitol in the dose of 0.5 to 1 gram per kilogram of patient weight, and bicarb in the dose of 20 milliliters per liter in pediatric cases and 25 ml per liter in adult cases. Mannitol is an osmotic diuretic and has a protective effect on renal function, the brain and the heart. Both crystalloids and colloid priming fluids have some influence on normal blood coagulation system and hemostasis, platelet aggregation, antithrombin 3 levels, circulating factors 8, von Willebrand factor levels, APTT and bleeding time levels are altered following cardiopulmonary bypass. Now once the surgeon passes the bypass line from the operating table, the first line we usually connect is the venous line to the venous reservoir, followed by the arterial line which is connected to the outflow of the oxygenator. The cardioplegia line is again taken, and in our unit we use a loop of cardioplegia to de-air it prior to being used in the patient. Now once the lines are passed, the recirc line is clamped and the main roller pump is turned on to de-air the AV loop. Mind you, before the AV loop is passed, the whole oxygenator and the cardioplegia unit had been de-aired and primed. Now it's only the AV loop that has to be de-aired. Now you can run the roller pump to full flows because it's the AV loop which is either half or 3/8 in size, and gently running the volume along the arterial line and getting the tubing de-aired is the norm. Now once the surgeon passes the AV loop to the perfusionist, the venous side and the arterial limb of the CPB circuit is connected to the CPB machine and it now forms a closed circuit. Now the AV loop has to be de-aired and primed, and gently the roller pump is turned on to move the volume along the arterial line and to make sure that the air is driven from the line back into the venous chamber. During the process, the lines are gently tapped to just make sure that there are no trapped air bubbles. And once the perfusionist and the surgeon is happy that the line is primed, the lines are clamped by the surgeon and then divided. Now in our unit, we prefer the CPB console to be positioned near the operating table opposite the main operating surgeon. Now whatever the position of the machine, the pump should be placed in such a way that the tubings have minimum length to the cannulation sites so as to decrease the required priming solution and hence the required hemodilution upon initiation of cardiopulmonary bypass. So what happens to all this priming volume we have used in the cardiopulmonary bypass circuit? First, one has to assess the urine output. Second, the loss, the external suction, what it has sucked and to what extent the volume happens to be seen in the wall suction. Third, the losses that happen through the sponges and mops. Fourth, the volume that is there in the vent and cardiopulmonary lines and the AV loops. And fifth, the amount of volume that's there in the oxygenator and the reservoir. And the fifth one would be, one has to consider the insensible loss when a large cavity is open for surgery, and it is to the extent of 2 to 10 ml per kilogram per hour. One has to also consider whether the patient is subjected to muffing or cuffing in pediatric age group and to assess the net volume gain or loss. Now, what are the disadvantages of hemodilution? Now, excessive hemodilution in cardiac surgery is a major risk factor for blood transfusion and has been associated with increased morbidity and mortality in relation to the degree of hemodilution. One has to also consider the impact of hemodilution that occurs from the anesthetist point of view before the patient is put on cardiopulmonary bypass in terms of the volume that the anesthetist administers to correct the volume deficit or to maintain the hemodynamic. So this volume administration by the anesthetist may also exacerbate the hemodilution that is experienced with the cardiopulmonary bypass, and both put together will lead to a lower hematocrit than expected whilst the patient is on CPB. Now, several studies have shown that the lowest hematocrit during cardiopulmonary bypass is an independent risk factor for morbidity and mortality in cardiac surgery. There is every chance that the patient will be subjected to low cardiac output. If it is less than 24%, then the chances of acute renal failure are very high. If the hematocrit falls below 19%, mortality rate is said to be twice as high as with an hematocrit more than 25%. So these are all studies that have been reported in the literature. Therefore, hemodilutional anemia is a major cause of blood transfusion in cardiac surgery, and there are very high risks associated with this transfusion in terms of immunomodulation, transmission of viral diseases, allergic reactions, hemolytic reactions, transfusion-related lung injury, and increased risk of infection. Also, blood transfusion has been linked to a decreased short and long-term survival in patients undergoing heart surgery. The risk of low cardiac output is very high when the hematocrit is less than 25%. There is an exacerbation of acute renal failure, and there is an increased risk of post-op complications as well. Literature reports the outcomes to become worse with anemia and get poorer with blood transfusion in heart surgery, so one has to be very careful regards hemodilution and has to keep an eye on hematocrit that shouldn't be less than 25 in adults and 30 in kids, though there is no consensus on this number. One can reduce the risk of significant hemodilution by minimizing the amount of dilution from the CPB prime, by lowering or shortening the CPB circuits, and by practicing retrograde autologous priming. Now, retrograde autologous priming can reduce the severity of hemodilution, but it is not appropriate to all operations and it may not work for every patient. And the safety and efficacy of this technique can be limited by the patient pathology, the clinical situation, the patient size, and the tolerance of the patient to the procedure. However, fluid may also be removed and blood concentrated during cardiopulmonary bypass by using a hemodialyzer, conventional or modified ultrafiltration, and by using D-cuff. So in essence, the single lowest hematocrit that the patient experiences at any point during cardiopulmonary bypass happens to the value that matters the most. Now this value is oftentimes the lowest after the start of CPB, because as the CPB continues, there will be increased urine output and redistribution of fluid into interstitial spaces, thereby increasing the hematocrit. Now, the other disadvantages of hemodilution would be a decrease in oxygen carrying capacity, tissue edema in various organs, reduced neurocognition, It can increase the mortality and morbidity by increasing the fluid in the lungs, and it can also alter the pharmacokinetics and pharmacodynamics of drugs because of altering the protein binding of the medications. And drug kinetics are also influenced by temperature, pH, and oncotic pressure. So there are newer experimental priming solutions that have been tried to overcome all the serious effects of either blood being used as a priming solution or either using crystalloid and colloid or balanced solution as priming solutions and to avoid hemodilution. They are all oxygen-carrying solutions in the form of perfluorocarbons or stromafluorohemoglobin, cross-linked hemoglobin, polymerized hemoglobin, or conjugated hemoglobin. So if you like the video, please click the like button and subscribe to my channel. Don't forget to ring the bell just to be notified of my next video in time. I would really appreciate if you can leave some constructive comments for all of us to learn, and also keep watching this space for future videos. Till then, thanks for watching, thanks for your support, thank you.